remove that. Okay. No, it's okay. Yeah, good evening, everybody. It was great talk, sir. And after following after you, I thought basically some clinical guidance I would like to give to the younger generation. I think sir has made it clear that it's no question of saying that imaging is not useful. My eyes can see everything, and all that dialogues are not correct, non-scientific. He was very clear about it. But many of you feel you have OCT and IVUS, which one to prefer when you have some things. I thought I would briefly cover up those. And this slide brings best wishes from Apollo Group of Hospitals before and my fax professional service colleagues, and we recover in multiple hospitals. The display is not coming. Why? I don't know. Anyway, so we have written one article in one of those books that didn't come out. If you want, you can go through that article, when to prefer IVUS, when to prefer OCT. I can give it there. And some of the articles written by Professor Rajesh sir also sent to you in as soft copies. I think this question, whether imaging is useful or not, I think should be best kept aside, because Greg Stone, in the recent ESC meeting, had got published also, compiled all the relevant updated network meta-analysis, which included 12,428 patients, and then included both OCT and IVUS studies and combination, and showed what it showed. It showed very clearly that imaging-guided PCI, be it OCT or IVUS, will come to that comparison later, decreases TLF by 31%, and the target vessel myocardial infarctions significantly, and then probably TLRs by 29%. 1/3 patients it matters. But only thing is you have to do it in right patient, not for a type A type of lesion. But in the complex PCI scenarios, it always helps. I think whether imaging helps or not, that is no question, no discussion on that. Further, after this network meta-analysis in 2023. And then what it also shows significantly is nowadays we do very complex procedures, long stent lesions, and stent thrombosis comes down significantly by 52%, and all-cause death by 25%. Stent thrombosis is a dreadful complication, which we all know, which is decreasing by half. It has to be given proper credence to it. So that's why I want all of youngsters to know, go out with this data, that imaging is useful. Now that we have, I think we should go to slideshow. It's not projecting there. Many of the things are not coming. Yeah. I think now the various modalities, the basics have been covered by sir already. I wouldn't go into details, but suffice to say that they're complementary. If you can afford, you want to have both in your lab, that's the best. You can use it when you want it accordingly. But many of the times, many of the centers are challenged financially, keep asking which one to be used, then those details we will see. But as you understand, the OCT resolution is very high. So anything more superficial, more detailed things, you see it better. But IVUS has more depth of penetration. So anything deep in the artery, you would see it better by IVUS. That is understandably so, no? Something which can see deep, you can see. Welcome, Dr. Sandeep Mishra, sir. So deep one, you can see better by IVUS. Anything superficial, where the stent endothelialized or not, such things will be seen very clearly by OCT. That is, I think, in principle, you should understand sensitivity, specificity are a matter of semantics, but basically both are equally sensitive. This, I would like to throw some importance on this. This is a SKY statement which came recently in 2023, showing applications of IVUS and OCT, which is again mentioning clinically relevant things. If you have to assess the left main disease, which is very big vessel, probably IVUS scores over OCT. And if you are de novo lesions, then what is that you are trying to see? If you want to see the thrombus, plaque rupture, dissection, which are very superficial, you see, which is just within the endothelium. Those are all seen better with OCT. If you see what is inside the vessel, that is plaque burden or positive remodeling, vessels expand, and aneurysmal situations, those are seen better with the IVUS. This is a conceptual thing. If you understand it is better. And aorto-osteal disease, many of the times we struggle to use OCT also in osteal lesion. I will show some 1 or 2 examples. It's not very great. Osteal lesions, that's where IVUS predominantly scores over OCT. Whereas if you see stent optimization, expansion, apposition, the gaps between the wall and the stent, seen it better. Again, it's a micro level, millimeter levels that is seen better with the OCT. And then inside the stent, neointimal hyperplasia, again, when the patient is coming with ISR, OCT has an advantage. But renal impairment, again, people try with saline, various types of other modalities to study with OCT, but I don't think you need to do so much struggle. And if you have a renally compromised patient, there's no doubt that IVUS is preferred. I want to be unbiased towards companies as clear as possible for the youngsters' sake, yes, please. So osteal lesions and the renal impairment and the deeper structures are seen better with IVUS, whereas superficial things, minor dissections within the stent, ISR, what has happened and all, seen better with OCT, clear. And this also shows the types of instant results. It's mandatory now to treat ISR patients with imaging only. If you do not have imaging, it's preferable to send patients to a center where imaging is there, because decision making happens depending upon what was the cause for ISR. That's very important. If you have a stent which was under-expanded, then probably if you expand with high pressure balloons and probably make it more optimal, that itself would be suffice. And whereas if you have such sort of neointimal hyperplasia inside, neoarthrosclerosis, that's where you need to work on it, and that's where you might need to help of putting another DES or DEB. How you decide, we will see it. This is possible both with IVUS, which is shown here, and also with OCT, which is seen here, but probably OCT scores shows it very clearly. Then the thin cap fibroathyroma also, which again superficial thing, is shown better with OCT. Now that we know some of those things, the trials were conducted with OCT IVUS trial with the 2,000 patients, 1,000 in each group, and try to analyze what is the target vessel failure and myocardial infarction, TLRs, which will be different at 1 year. Obviously, it is very difficult to produce any significant difference. The result came out is there's no difference in both imaging modalities in this OCT IVUS trial. Then that is why don't go always by trial results, develop our own protocols. That's why I wanted to just throw you some more clinical information and highlight which one you prefer. If you see, when are this imaging is used particularly, we have diagnostic dilemmas like whether borderline lesions, you can measure directly areas apart from FFR. And then you also have a plaque characterization where calcium is more, whether you have to use what type of cutting things, and all you'll all get decide by that. And the PCI techniques, again, can be more precise. Now, your exact size of the stent and the diameter. In a recent NIC meeting, I was telling, everything, Gary Mitz was there with me. We measured the length, we measured the diameter. So he exactly told what type of stents to be taken, how much to be deployed. It is only becomes very easy to take that size of stent and go there and deploy it and come out. So that sort of precision is possible. Exact length, you may say that most of the stents you can expand either higher or later. That way you can do whatever you want, but you have to do it right, means you have to follow these precision techniques and do the right thing to the patient. Then pre-intervention, post-intervention, stent optimizations, whether stent is malapposed and all that, again, you take this help. And follow-up assessments with ISR type of dealing, stent endothelialization, we see it. Left main, again, it's mandatory. Bifurcation disease, again, preferable or mandatory to use in the scenarios with imaging. Then IVUS advantages, as I was mentioning, it's easy to acquire images. You can take it catheter inside and come out. You can repeat many times, no contrast involved. That way it is easy to do. You can do it in sick patients and patients with LV dysfunction, patients with CKD. There's no problem because you can always image and get it out. Image from the start to end, right from the guide catheter till the guide catheter comes, osteal lesions. Again, how much ever length, you can do that. Then because of higher penetration, again, the arterial wall, and you see it better inside up to the media. You get better areas also to calculate the stent sizes. That's why there are algorithms created to size the calculation of diameters. It will become bigger with IVUS compared to OCT. I request Professor Sir and the senior Sandeep and all to excuse me because I thought to cover it basics even for sake of youngsters. Then IVUS can visualize deep and the plaque burden overall also is better. This, I think, a standard cartoon which you all know. The areas I wanted to highlight. Initially, it was told 5, 6, 7, 8, but that's the minimum what is said. Now you aim for a little higher. The bigger is the better. 6, 7, 8, 9, 10 is what we should get areas by IVUS. That came through IVUS. Again, disadvantages of IVUS are you get some sort of images because of low resolution. Sometimes you may not be able to identify everything. Normally, many of the times you run the catheter, IVUS comes out, but you have a little longer learning curve. Unless you keep doing it in more patients, sometimes it becomes challenging for you to interpret. But with a better quality HD IVUS catheter coming up now, this sort of thing is a learning curve also can be shortened now. And sometimes you face a struggle to take the catheter inside the calcific structures that is there even with OCT. So, but easy to do, but slightly difficult, longer learning curve, and you are getting experience. The clinical scenarios, as I mentioned, sick patients, severe erectile dysfunction, CKDs, osteal disease. Now, CTOs also we started sometimes to get an idea, zero contrast or low contrast PCIs. Anyway, you can't use OCT there. And some of the ectatic aneurysm circuit. Please remember these. These are the clinical scenarios where we prefer using IVUS or OCT. Then I'll show you 1 or 2 case examples before I go on to OCT. See this, this is a very critical left main osteal disease. If you some of these views, you may totally miss it. That's why Rajesh sir has covered in the osteal left main, what is the image angles which you use. Elevocranial shows the best. See that it's the tightest thing. The patient had sicker LV dysfunction, we have to use impeller. All that is not the point of discussion here. But see that sort of thing you may miss totally if the catheter goes deep inside. So we did IVUS, then it shows very clearly large of plaque burden. I think because of the light you're not able to see. Huge plaque burden, once if you run it slowly, it comes, the tightest lesion comes and then the guide comes. That means immediately after that osteal lesion it is, you can measure the areas and then probably decide on it. There are multiple steps involved it, for the sake of time I edited it. And we have worked on the LAD here and then probably worked on the left main and then finally optimize the results and check post also. When you get circular areas and 13.5 was the area, the patient did well and follow. Another example is osteal RCA disease. Sometimes you get a doubt whether it is spasm. Then if you see imaging catheter, then the probably area was less and we addressed it by stent. Then you get good stent areas post. Then you have no doubt that sort of things by IVUS. We tried to do in a conference live demonstration because we were already taking OCT. The people are trying to, such out of OCT catheter, contrast doesn't get washed out. You take this catheter deep inside, and we are nowadays using this guide extension catheter, especially telescope, which has a radiolucent thing and goes inside and images a structure like this. So you still get, this is a telescope inside, you can still get into the artery and then image this sort of thing, but it's very difficult. I don't want to use to trouble and try all this. If you have IVUS, we can straightly use this. And then we coming to the disadvantages of OCT, as we said, sometimes it is difficult for it to use. It can't be used in LV dysfunction patients and CKD patients. But where is it preferable? The ISR type of situations, whether you want to study whether endothelialized stent is done or not, or stent is expanded, Mala post or not, then this gives a very clear-cut images for us, for all of you, for easy to understand. And then for bifurcation, again, it's a great advantage, I would tell you, to have the bifurcation views and things like that for OCT. So stable patients and smaller vessels, bifurcation lesions, then post-PCI assessments and assessments of dissections is a OCT scores or IVUS because very easy for all of you to understand and see. I will show you some case examples. The plaque morphology inside, again, what type of material it is, again, also is slightly seen better. And you see such sort of clarity like histology, whether intima, media and all that, but deeper structures, it fails to show. Unlike then, depending upon the plaque morphology, which is already discussed extensively, you decide the modality by depending upon what type of calcium you are getting it. This algorithm is also covered by Ajay already. This is another case example I would show. This acute coronary syndromes is another area where we tend to use OCTs nowadays. 31-year-old young fellow coming with this sort of ugly lesion. Now you see whether you have to stent it or not. You nowadays do OCT and then decide. See, we gave heparin, waited for 2-3 days to restudied him again, but still it was persisting. Then if you decide if this sort of only rupture plaque is there inside, then probably you need a help of stent. It won't go away. If it is only like erosion without much of plaque inside, then you can get away without stent. So this was having that sort of plaque ruptures inside with a plaque there inside. So we had to stent it. And once stenting is done, you had a good result. So decision making will be done by that, and you can calculate areas and other things. If you have to see stent whether it is expanded or not, it's under expanded stents. Very clearly, you see compared to this, you see the areas are very minimal, crumpled. We have no doubt in saying that stent is under expanded there. We have criteria 20% of under expansion is okay, but if still that sort of horrible under expansion with minimal areas, you would clearly dilate it again, get a good result. Some sort of this sort of malappositions, minimum 3 mm distance is okay, but if it's more malopposed, then probably you would work on it with again high pressure dilatations and you would get it. In that process, sometimes you could end up with edge dissections. You should be careful to keep it the balloon width inside. And this sort of dissections and intramural hematomas is very, very clearly seen with OCT. And ISR type of pictures, what type of material inside, I can't go into details. With one more talk, I try to show more of ISR pictures. The decision making is done by it. So one or two case examples of ISR I'll show, and my time is up. It says I'll close. This is out of patient presented initially, long time back, history of MI, RCA was done. Now he comes back and then he had RCA occluded like that. Then you wire it. Then you do imaging. Wherever stents were there, that's why I keep telling that stents work well. When there is no stent, then probably had more occlusions. So the philosophy behind this is taking long time to run, but basic philosophy, I will try to project it here. If you have a stent in which there is a restenosis come, we try to avoid a second layer of stent, if possible, do a regulating balloon. But if the lesion is de novo, where there is no stent before, that's where we tend to take the help of regulating stents again second time. If the already DES was there, we just use a DEB after preparation. And where the de novo sites where it was not there, so entire artery, that is the principle. We worked on it and entire artery became normal. Again, documented everything by OCT. That final result came out well. This is another patient which is recently done. He was distal LCX was stented. Here he had developed a one more lesion proximally. When we did this, looked very mild to us an angiogram. But when he did OCT, see that intra-stent, the areas are very less. So sometimes this could be misleading, especially the more distal we go. So this patient, we prepared aggressively. Here we did a DEB and here we did a stent. This was de novo lesion. So idea is if you can avoid stent with the DEB, it is better. This is another 79-year-old patient, came back after 10 years. With the places where the stents were not there, we did tests. And then when patient's osteal lesion, again, we used IVUS in spite of patient coming with post-stenting restenosis. So these sort of pictures we can just document at the end with little contrast and work without much of thing. OCT, a word about OCT in bifurcation. A lot of advantages. You can see the ostium struts. I think sir has already shown this, one of those examples. But when you're not dilating, sometimes patients come back. That's what we say. It helps in this fly-through views, such sort of amazing pictures you get with OCT. That's to conclude. Don't know. Conclusion didn't come. Oh, sorry, man. This is an important slide. I don't know why this is not projecting. Is it coming now? Can you show? Can you connect again? Can you project this? Last slide. Yeah. So if you have osteal lesions, CKD, severe erectile dysfunction, sick patients, CTOs, do IVAS. Then if you have ACS, morphology of lesion assessment, post-stent, you want to see whether the stent expanded, mal or post, in stable patients, and also on work bifurcations, probably you could see OCT. You could be, but by and large, I would say 80% of the times you could do get away with either of it. But there are some preferences which I try to highlight, which will help you in selecting which imaging in your day-to-day practice. Thank you again. This was a highly successful TCT India South Asia 2023. And again, in 2024 July last weekend, we do it here. Request all of you to block your